abnormal weight gain, and then that have, finding it difficult to lose weight.
Yes.
Because you see in PCOS,
Yes.
50% of the patients are obese.
Unfortunately, at the moment, we do not have a cure for polycystic ovary syndrome, but there is ways of managing it. Especially in sub-Saharan Africa, there is a lot of paucity of data. And the prevalence is, like I had said earlier, is quite high. So compared to the global prevalence, it's even higher. But now in Africa, we are catching up as well because of changes in lifestyle.
What advice would you give to someone who, we had more than a very large percentage of women have PCOS and do not know because they have not been diagnosed. So are there specific either questions or actions you'd advise a woman right now to just make sure she knows at least her status? Welcome to the MedSquad Podcast. My name is Yafesi Musoke. Now we'll be looking at two topics that affect women's health, PCOS and endometriosis rather. Both of these deserve their own deep dive, so we're going to take them one at a time, and we'll start with PCOS. And I have with me my panelists who will introduce themselves starting from my left.
Thank you for having me. My name is Dr. Flavia Bagatia. I'm a medical officer, and I'm very passionate about women's health.
Yes. Good to have you.
Thank you.
Thank you for having me as well. My name is Mbuche Mzungu. I'm an obstetrician and gynecologist by training. I'm very passionate about women's health, and my particular area of interest is fertility.
All right. Now, it's good that you mentioned fertility, because when we talk about PCOS, first of all, what is PCOS? What does it stand for? And is it true that it's one of the biggest causes of infertility in women?
So PCOS is polycystic ovary syndrome. It usually affects women in the reproductive age group. And there's a certain criteria that we use to say that someone has PCOS. That is called the Rotterdam criteria, and it has three things.
Yeah.
So number one would be irregular menses or an ovulation. So irregular menses is menses that the cycle is less than 21 days, or the cycle is too long, meaning the cycle is more than 35 days. And yes. And then an ovulation means that sometimes you can have ladies who have regular menses, but then they're not ovulating with every menstrual cycle. Yeah. And the way you diagnose that would be from symptoms. The patient can tell you that they are not seeing the classical mid-cycle ovulatory symptoms like your mucoid discharge or a bit of lower abdominal cramping and such. And then the second criteria usually has to do with excess of androgens. So androgens are male hormones, and this can be diagnosed either clinically or using lab markers. So clinically, we can have women who are presenting with acne, abnormal hair distribution, male pattern, a beard, a mustache, hair on the chest, and things like that. And also male pattern balding. And then yes.
So there's both appearance of hair and also hair loss. Like if it's facial hair.
Yes.
Oh.
So there is appearance of hair, male pattern, which is called hirsutism. And then there is balding, which is loss of hair on the head.
Yeah.
Yes. And then for the lab, when we do serum levels of either testosterone or androstenedione or another hormone called DHEA, then they can be elevated in certain groups of women. And then the third criteria is where they have polycystic ovarian morphology. So polycystic ovary means we do an ultrasound, and we are finding that one ovary has more than 20 follicles, usually measuring between 2 to 9 millimeters, or the volume of each ovary is more than 10 mils. So for the criteria of diagnosis of polycystic ovary syndrome, we have to be a bit careful for adolescents. So for the polycystic ovarian morphology, that criteria is usually not used if the lady is within the first 8 years after onset of menses. Yes.
So that's from okay, they're different ages. Some start as early as 9.
Yes.
Yeah.
So you count 8 years from when their menses began.
Yeah.
And then if it's more than 8 years, then you can say you're using the cutoff criteria of either your 20 follicles or 10 mils, because younger girls tend to have very dense ovaries.
Yeah.
Their ovaries are a little bigger than older women.
Okay.
Yes. And also for the irregularity of the menses, it's usually 3 years after the onset of menses, because the first few cycles, spanning from maybe a year up to 2, they can have the irregularity of menses because the hypothalamo-pituitary ovarian axis, which is what controls the menses, is not mature yet.
So,
yes.
Hey, you've mentioned a lot of technical terms. What I'm wondering is now, so for a young lady, when she comes to her doctor, does she ask for these tests?
Mm-hmm.
And if so, on what basis? Like, what symptoms should she be looking out for?
Yeah, so women should advocate for themselves when they go to hospitals, and also it's important they look out for certain symptoms, signs and symptoms, like you said. For example, yes, the menstrual cycle, the periods are irregular, and then they are having months without periods.
Mm-hmm.
It can be about less than 9 months in a year. Mm-hmm. The period can be less than 9 months in a year.
Oh, instead of every month?
Yes, instead of every month.
Okay.
Then they can also be abnormal uterine bleeding. Then they can also look out for what doctors say, the hair, the hair distribution. There can be hair above the upper lip. There can also be hair on the chin, just like the male pattern distribution is. And then there can be hair on the chest, and then there can be loss of hair.
Yeah.
They should also look out for abnormal weight gain.
Yes.
And then that finding it difficult to lose weight.
Yes.
Because you see in PCOS,
yes,
50% of the patients are obese.
Mm-hmm.
Then also when they're having problems getting pregnant, giving birth, because in PCOS we have an ovulation.
Yeah.
What happens? Normally, the follicle should mature and release an egg. In PCOS, we have so many follicles, but they're not maturing, so there's no egg released. And then...
Oh, when you mentioned follicles, because the name, of course, poly and cyst. So for me, I was thinking at first it has to do with cysts. Are we talking... Is it the same thing when you're referring to follicles and cysts, or is that just the name that was given?
It's just a name that's given to the morphology of the ovaries, because we are saying the criteria is, so the characteristic appearance on ultrasound would be, it's called a string of pearls. So you see an ovary with black spots around it. That is the follicle. So imagine the follicle as an egg that has a shell, then has a yolk inside. Yeah. So this is the shell. The follicle is the shell, and the egg is in the inside of that follicle. But what is referred to as cyst, when, for example, a doctor tells you that you have an ovarian cyst, the definition is a little different. The measurements usually are about 2 centimeters and above. Okay. Then we say that's a cyst. But for polycystic ovaries, the measurements are usually between 2 to 9 millimeters. Okay. And characteristically in the periphery of the ovary.
Now, having received that diagnosis, is there a cure, or like what are the treatment options? Is there a cure?
So unfortunately, at the moment, we do not have a cure for polycystic ovary syndrome, but there's ways of managing it. Yeah. So the management really is contingent on what the presentation of the patient is and the bothersome symptoms. Yeah. So for example, if a lady comes to you and their issue is irregularity of the menses, meaning that maybe their menses are too frequent and you want to regularize the menses, then you give them the options for regularization of the menses. Yes. These options include hormonal treatment that will regularize the menses so that they are not bleeding too much and going into anemia. If the issue with the patient is, for example, difficulty in achieving a pregnancy, then you treat them for that. You will put them on ovulation induction drugs. There's a lot of drugs that we use for that purpose. So you have a lot of eggs. It's like starving in plenty, kind of. You have a lot of eggs, but you're not ovulated, so you cannot get pregnant. Some of the drugs include things like letrozole, clomiphene, and sometimes where it's very difficult, we even go to what is called gonadotropins. These are drugs that are commonly used for in vitro fertilization. So we can go to that extent as well. And then if they have issues with body image, someone is having a difficult time losing weight, then obviously you can tailor, say, their lifestyle. So to do with diets in collaboration with a nutritionist, you can even go to the extent of having bariatric surgery as well, because if they lose weight, the fertility usually improves. And
what is bariatric surgery?
Bariatric surgery. So these are surgical interventions for weight loss. Where you can get something like a gastric sleeve. So the size of your stomach is reduced so that you're not able to eat too much food, or you get bypass surgery and things like that.
Now, in line with that, because you've talked about body image. So some of them might be, let's say the younger ones, my body weight is fluctuating up and down, and then I have acne also. And I may not be aware that this could be something to look out for. So the first thought might not be to go to my gynecologist. It might just be to go and do beauty treatments or something like that. With that in mind, what is the impact of or the long-term impact of not getting the correct diagnosis? Because I might be thinking it's just a genetic issue with my skin or something else to do with hormones. So what is the impact of not getting the right diagnosis?
So PCOS in turn causes metabolic syndrome, where someone can end up with diabetes mellitus and type 2. And it's because of insulin resistance. So PCOS also comes with insulin resistance. And then they can end up hypertensive, and then they can get what we call sleep apnea. These are repetitive pauses of not breathing when they're sleeping.
Yes.
Yeah, so that puts them at a risk of getting cardiovascular diseases and ending up with hypertension. Then also they're at a risk of infertility because, like we talked about, there's no ovulation, there's no egg released. So they're infertile. And then they can end up with endometrial cancer, cancer of the uterus, because of you have hormonal imbalance and prolonged estrogen exposure. Yes. There's also depression. It comes with a lot of mental stress. So these people end up depressed. So they need psychosocial support.
So it kind of it's like a vicious cycle if you don't get the right diagnosis.
Exactly.
Wow. You're on the MedSquad podcast. There's lots of information here. But when we come back, we'll be finding out about resources available and support systems right here on the MedSquad podcast. We'll be back. Hey there. Welcome to Zuri Health HQ, where Africa's finest medical minds meet modern care. I'm Yafesi, your host on the MedSquad.
Care is personal. It's not just diagnosis, it's direction. From a cough to managing chronic illness, we listen and we lead.
Every symptom has a story. We listen, explain, and act together.
Nutrition is not just about food. It's fuel, it's healing, it's prevention. We help you eat with purpose, for energy, for recovery, and for lifelong health.
We are not just lab coats, we are detectives, and your blood speaks when we translate.
Your mental health is not a luxury, it's your health, period. Whether it's trauma, depression, anxiety, or even wanting to speak to someone, we are here for you.
At Zuri Health, collaboration is our strongest prescription. We connect expertise across Africa to deliver care that is smart, affordable, and people first.
This is the MedSquad. Real conversations, real health, real people. From your inbox to your bedside, we're with you. Welcome back to the MedSquad podcast. We're talking about PCOS, which in full is the Polycystic Ovary Syndrome. Now, the honestly, hearing some of the symptoms that you've spoken about. Oh, by the way, I have Dr. Mbuche here and Dr. Flavia, and my name is Yafesi. Okay, I'm just learning. I'm definitely seeing it from an outsider's perspective, but hearing these symptoms and hearing the potential long-term effects, I'm wondering, are there resources available or education out there? Because like it's not as widely spoken of as, say, endometriosis, because whether it's because of one person taking on the campaign or media just not being aware. So what resources are available if someone needs to find either other people, or is there education out there for someone who might be prone to PCOS?
Okay, so the unfortunate thing is there is not a lot of information out there on particularly those two conditions, both PCOS and endometriosis. Even when you're looking at the African studies, especially in sub-Saharan Africa, there is a lot of paucity of data. And the prevalence is, like I had said earlier, is quite high. From 16%, this was a study out of Nigeria, up to 32% in some studies out of Tanzania. And there's even a study, 2018 study done at the Kenyatta National Hospital, that was using the Rotterdam criteria to diagnose Polycystic Ovary Syndrome in patients who had presented to the clinic with either their menses having disappeared or infrequent menses. And I'm telling you, the figure was astounding. 49% from that group of women actually did fulfill the criteria that they did have they did have Polycystic Ovary Syndrome.
Half of them?
Yes. So considering that, maybe we can leverage on both print and digital media to spread the word out and be advocates for these patients.
Is there maybe a measure of stigma, or I don't know what it is that's preventing people from either coming forth, or the statistics you mentioned? How do they compare globally with the global average, if that information is out there?
So there's a lot of stigma, and it's considered taboo, especially in our African setup, to talk about menstrual issues. So usually what happens is you get a girl getting their first period, and it's irregular, and the immediate family tells them, the mother or the aunties, it's okay, I also had the same thing. And then once I had my first baby, it got better. So sometimes these issues are not talked about. Yes. So compared to the global prevalence, it's even higher. But now in Africa, we are catching up as well because of changes in lifestyle.
Now, you mentioned lifestyle, and that actually brings me to my next question, because we're looking here at the causes. What causes? I mean, I'd be thinking we're trying to find ways to prevent it. So what causes should we be looking out for? Are there people who are genetically predisposed to PCOS?
Oh, yes. PCOS has a genetic predisposition, but also combined with other factors like environmental factors. We're looking at people who have, like we said, obesity, and then insulin resistance. People with diabetes can have a higher chance of getting PCOS than.
Are there some that are especially, I don't know, like special causes? I mean, we talked about diabetes and I don't. Did you mention hypertension, or is that also?
No,
it's not. Okay.
What I would call a special cause is insulin resistance.
Welcome back to the MedSquad Podcast. My name is Yafesi Musoke, and I'm here with Dr. Mbuche and Dr. Flavia. We're talking about PCOS, and by now, I'm sure you have plenty of questions that you can ask to your doctor. However, we do live in a world of convenience. and everyone wants to be able to do everything on their own in their own private spaces. Are there tools available, like any, I don't know, whether it's innovations or something, so that I can at least suspect, if I suspect that I have PCOS, I can confirm it and go see a specialist?
Yes, there's a tool that we use. It's called a PCOS questionnaire that captures emotions. Someone who is affected, their emotions. We're looking at their body weight, the body hair, because there's that male pattern hair distribution, and then there's fertility, infertility issues. Then also look at the menstrual cycle, whether it's regular or irregular.
So it's you fill it out, and is it based on a score or sorts? Then you can find out.
Yes, kind of like based on a score, because like doctor said, we are using 2 or 3 symptoms from the criteria to diagnose the disease.
Okay.
So you just can't have one and you say I have PCOS. You have to use 2 or 3.
So do you take the score, like, or the printout, or just the results, and take them to your doctor, or what's the process after filling in the questionnaire?
So maybe I could take it from there. So if it's strictly for the diagnosis is based on the Rotterdam criteria. This questionnaire is just, it assesses the quality of life of people with PCOS.
Okay.
And guides us in the management. But it's not for diagnosing PCOS. So the diagnosis of PCOS is strictly based on the Rotterdam criteria for now.
And that one is with your doctor, with your gynecologist?
Yes.
Wow.
Yes.
So is there anything specific, like, what advice would you give to someone who, I mean, we had more than a very large percentage of women have PCOS and do not know because they have not been diagnosed. So are there specific either questions or actions you'd advise a woman right now to just make sure she knows at least her status?
Yes. So what I would advise women would be, number 1, listen to your body. You know what's normal for you. So you would be able to discern what is abnormal. And then number 2, what is very important is keeping a menstrual diary. So this diary, the day your menses start, you chart it. The duration of your menses, you chart it. The regularity of your menses as well. And even the the quantity of your menses. So that if you go to your healthcare provider, some of these small details is what is going to differentiate. Is this just a normal variation, maybe based on stress, or is it really PCOS? So it would start from a menstrual diary so that you're able to help your healthcare provider help you.
Okay.
Yes.
So as a question comes to mind, of course, is there a role, and if there is, what is the role of herbal, either treatments or, I don't call them medicine, just herbal solutions in PCOS?
So there could be a role of Ayurvedics, that is alternative medicine, in the management of PCOS. The problem with these herbal remedies is that, number 1, we are not sure of their mechanism of action. So we really do not know by what mechanism are they controlling the symptoms. And then number 2, there is also no evidence of what is the dosage, how much do I take, and for how long. So there could be a role, but on the flip side, it could delay people from seeking medical treatments for these problems.
So in line with that,
that would be my comment.
Okay, so then regulating is a bit difficult. So in line with that, is there a framework in general, whether it's government framework, whether it's policy, whether it's advocation? Is there any for PCOS, or are we going case by case for now? Because it doesn't sound like there's much confidence in a system or in a structure that works for people who may be living with PCOS.
I would say there's no framework because it's more case to case basis. they come to hospital and we diagnose them. And then we need to create more awareness on talks like this so that we increase demand. Someone is aware that they have these symptoms, and then they go to the facility. So there you increase the demand for seeking care. And then in that, we'll create more, the policies will be directed to that particular cause. But also we need protocols. Like, and then like screening tools. What does someone based on to diagnose it? And then especially the protocols. We need the protocols to manage the disease.
Okay. In terms of gynecologists and obstetricians, are they all, would you say they're all trained in this? This is just part of the normal training, or are there some who are, is there like extra training you have to get to be better versed in PCOS?
So that's a very good question. Before we even get to the specialist, obstetrician gynecologist, let's start with the general practitioner. So a lot of general practitioners actually don't have this information. So you will get a woman presenting to a clinic with irregular menses year after year, and what they're being told is you have hormonal imbalance. They're just put on the pill, come after 3 months, and then they have a period of regular menses, and then it recurs without telling them what exactly the problem could be. So the training should start from the primary healthcare providers. For the obstetrician gynecologists, yes, things are getting better. Usually we are taught about Polycystic Ovary Syndrome in training. But there's a group of specialists who are endocrinologists. They deal with endocrinology and fertility. That group is maybe the highest specialization of the group of doctors who should be dealing with PCOS, seeing as these women might experience difficulties in achieving pregnancy and things like that. And then maybe just to add on to what Dr. Flavia said about advocacy, PCOS is a chronic condition. Under the current provisions, especially for the social health insurance that we have now, these kind of conditions are managed under the general, either outpatient or inpatient. But I think going forward, they should be included in the package that covers for emergency, chronic, and critical care, so that you're also able to cover for these conditions under that package.
They're currently not covered.
No, currently it's not considered to be a chronic condition. But these are women who will be in and out of hospital every few months with different problems. And then another thing would be insurances, even private insurances, especially if it has anything to do with a test that requires you to check the hormone levels, or you're prescribing a hormone. Most of the times, those are exclusions from the package, which is quite unfortunate. Yes. And also for assisted reproduction, because it's quite expensive for an ordinary Kenyan to get these services. So if we could lobby for social health insurances to help with such, it would be a good reprieve for the patients.
Wow.
Yes.
Okay, I have learned a lot. And this is just the first part of it. Remember earlier I told you about PCOS and endometriosis. We just touched on PCOS. Now, this is the MedSquad podcast. If anything here has been found useful, you found it helpful, please share this. Share the episode, share it with someone. And follow us on all our platforms. That's at the MedSquad Pod. And if you do have questions, inbox us. Let us know what you want us to address. We'll see you next time.